Hey guys, it's Professor Rich, and I'm going to go through the Module 4 PowerPoint with you guys. So on this PowerPoint, we're going to be talking about immune function, immune disorders, HIV and AIDS, and multi-drug resistant organisms. So immune functioning. We're going to just do a quick anatomy overview. We're not going to go too crazy. A lot of this is patho, so you can take notes, but I suggest just listening and try to understanding the system in general. So components of the immune system include the lymphatic system, primary and secondary lymphoid organs, and the cells and proteins involved in the immune response. The lymphatic system is a network of vessels that transports excess interstitial fluid that has not been reabsorbed. That's also called lymph fluid. And this transports it back into the bloodstream to help maintain fluid balance. This system contains thousands of lymph nodes strategically located superficially and deep within the tissues near the lymphatic vessels. We have the thymus. This is a soft organ. It's located within the chest cavity near the heart. It's large in children and decreases in size in childhood. It is the central lymphoid organ that produces thymosin. That's a hormone that stimulates T cell production, and it's where T cell development takes place. Bone marrow. This is where our B and T lymphocyte formation and differentiation of the B cells and T cells occur. B cells stay within the bone marrow to mature, and T cells migrate to the thymus to mature and become active as regulatory T cells, also known as suppressor T cells, or effector T cells, which are also known as helper T cells and cytotoxic T cells. The spleen is part of the lymphatic system, and that serves as a filter for the blood. The tonsils are located between the palatine arches on either side of the pharynx, and they function to trap and protect against bacteria and viruses that are inhaled. Adenoids, they defend against inhaled bacteria and viruses. Peyer's patches, those are lymphoid follicles, and they're located in the mucosa of the small intestines. So they're known as interstitial immune sensors, and they defend against pathogens that gain entry into the intestinal tract. So passive versus active immunity. I believe you guys covered this previously, but I did want to do a little overview because you do need to know it. So for passive immunity, this is when someone's given antibodies from another person or an animal rather than making them on their own. So for example, feeding your baby through breast milk is a way to give passive immunity, or the placenta actually passes on antibodies to the fetus, which is providing passive immunity. Active immunity, so that results from production of one's own antibodies for fighting off a virus or illness. So this is vaccines. So when you're given a vaccine and your body creates antibodies to fight whatever weakened or dead virus. Or it could be that you were previously exposed to something. So, I had chickenpox when I was younger, so my body has created immunity to it. Or, you have the flu. Typically, you don't get the same strain of flu within a year because your body creates antibodies and has some immunity to it. Natural active immunity is the longest defense. So our immune function, obviously, we have multiple lines of defense. If we were just muscle, like when you see those characters that are just muscle, we would have infections all the time. So our skin is an obvious barrier. So the first line of defense relies on anatomical and biochemical barriers for protection. These all work together and mount a passive defense against pathogens. We have epithelial cells in our skin, we have mucous membranes, protective linings of our organs, and these all provide protection against infection. And then on top of it, we have mechanisms of sloughing, so skin sloughs to get rid of any bacteria and stuff, coughing, sneezing, vomiting. Our gut is telling us, hey, this doesn't belong here. Vomiting, diarrhea, urination, we're voiding out that infection. So working with physical and mechanical barriers, biochemical surface, and glandular secretions such as tears, saliva, perspiration, earwax, They all provide a means of protection for our body. Initiation of the inflammatory response includes vasodilation and increasing permeability of capillaries stimulated by histamine to release those mast cells, kinins, and other inflammatory mediators such as prostaglandins and leukotrienes. Vasodilation increases blood flow to the inflamed area, which facilitates leukocyte movement to the affected site. This increases impermeability, allowing the leukocytes to move into the tissues to fight off that infection. This is an overview of the inflammatory response. I'm not really going to go through it. I will add this to your ticket to class. You guys can just kind of have a copy of it. I found it in the F.A. Davis book, and I just thought it was a really good, quick way to look at it. So immune function assessment. So as a nurse, how do we assess a patient's immune function? So for history, we're going to think about the patient's age. What medications are they on? Are they on something that is going to make them immunocompromised? Allergies, what allergies do they have? Do they have a current problem? Are they, experiencing an illness already? Medications, so like I said, when we're thinking of immunosuppressant agents, we're also thinking about antibiotics because they also fight off good bacteria. We're thinking of anti-inflammatories, anti-metabolics, chemomedications, antineoplastics, thyroid suppressive therapy. The medical and surgical history is important. Obtain that in addition to the family and social history because immunological problems are genetic and chemically induced. Nutritional status, infection history, any prior immunizations, chronic illnesses, autoimmune disorders, cancer. These all affect our immune function. So for the physical exam, so we're going to do vital signs. So you want to inspect the skin, the mucous membranes, palpation of lymph nodes, do an exam of the neurological, respiratory, cardiovascular, GI, GU, musculoskeletal systems. So you want to assess all those systems. With immune dysfunction, the normal inflammatory responses could be blunted. So we might only see like subtle changes. For inspection, so thoroughly perform a skin assessment, inspect each area of the body, look for hypothermia, hyperthermia, enlarged lymph nodes, look for edema. We want to look at the skin color, skin integrity. Do they have any rashes? What type of rash? Do they have lesions, hematomas, petechiae, purpura? Is their level of consciousness changing? Is their gait changing? Vision, hearing? It's also important to know any changes in the respiratory system. Are they tachypnic? Are they breathing heavier? Are they retracting? Are they coughing? Do they have nasal flaring? Urine. We want to collect it, look at it. Is there sediment? Is there blood in it? What color is it? Is it odorous? Stool samples. Do we see blood? Does that smell suspicious for like C. diff? Do they have diarrhea? Auscultate. Listen to those lungs. Listen for abnormal breath sounds such as crackles, wheezing, rubs, rhonchi. Know any decrease in or absence of breath sounds. Listen to heart sounds. Are they tachycardic? Are they bradycardic? Is their heart rate irregular? Are they having murmurs? Check for bowel sounds. Are they hyperactive, hypoactive? Are they absent? Palpate and percuss. Palpate the skin, check the temperature. Is it clammy? Is it hot? Is it cold? Look at the lymph nodes. Are they enlarged? Are they tender? With light palpation, move the skin over the areas where nodes might be palpable. Nodes should not be easily palpable in a healthy adult. And if they are, then they're usually enlarged, and this is a cause for concern. Explore the adjacent area and regions that are drained by the enlarged node for signs of infection or malignancy. Cancerous nodes are not usually as tender as those from an infection or inflammatory process. To assess the abdomen, perform light and deep palpations with percussion to assess for like the spleen enlargement or any palpable masses, the presence of abdominal fluid or abdominal pain. The liver and spleen could be enlarged because of infections, cancer, disease of the blood or lymphatic system. Look at the joints, mobility, pain, swelling, warmth, redness. So that's what we should be doing on our physical exam to check the immune function. So diagnostic studies. So blood tests. We're going to look at a CBC with differentials. That's going to give us the breakdown of red blood cells, and our white blood cells is going to give all of our differentials. So we're going to look at the leukocytes, the lymphocytes. We might do skin tests. We should do bone marrow aspiration and biopsy if needed. Radiological imaging could be necessary to evaluate their immunity, or immune competence, I should say. So immune deficiencies that occur can be primary or secondary. So primary, it is due to the aberrant development of immune cells or tissues, and secondary are due to outside interference of the normal immune system. Disorders that follow can be due to infection, autoimmunity, hypersensitivity, or gammopathies, which is an abnormal protein produced by the plasma cells. All right, so we have leukocytes. This would be white blood cells with differential, so part of that CBC, but specifically looking at your white blood cells. So the leukocytes, these are mobile units that travel through the bloodstream to defend the body against infection. Increased amount of leukocytes is called leukocytosis, and again, this is a response to defend the body against infection. So our normal value is 4.5 to 11.1. We have 5 different types of leukocytes, so we'll break down this differential. So 40 to 75% of them are neutrophils, and these increase when the body is responding to a bacterial infection. So they are phagocytes of early inflammation, and they destroy bacteria. 0 to 1% are the basophils, and these release heparin as an anticoagulant and histamine during early inflammatory response. Then 0 to 5.5% are eosinophils, and these are phagocytes that destroy allergens, and they combat parasitic infections. So often these are released in response to an allergic reaction. Then we have monocytes, and they are 4 to 9% of our leukocytes. And then we have our lymphocytes. So we have 12 to 44%, and these break into 2 components. So they're active in both humoral and cell-mediated immune responses, and they're formed in the bone marrow. They're found in the lymph nodes, spleen, the thymus, and they enter the bloodstream through the lymphatic system. Our B lymphocytes, so these are the cells involved in the humoral immune response. They're a subset of the lymphocytes that mature in the bone marrow and produce antibodies and immunoglobulins. Antibodies bind with the specific antigens, marking them for destruction by other components of the immune system. They can directly neutralize the antigen by inhibiting an essential function necessary for its survival. And then we have immunoglobulins. So we have the IgA, IgD, IgE, IgG, and IgM, and we will talk about them on a different slide. And then our T lymphocytes. So these are participants in cellular mediated immune responses. The T cell activation occurs when macrophages present the T cell with a phagocytized antigen. Natural killer T cells, they target virus-infected and tumor cells. As someone ages, the number of the NK cells increase, and this increase helps control infections in elderly, and it's important for successful aging. And we'll talk more about aging as well. Immunoglobulins. So IgA, this is found in secretions like breast milk, sweat, saliva, mucus, and tears. Then we have IgD. This is primarily on the surface of those B lymphocytes, and it plays a role in that B cell activation. IgG, this is less concentrated, and it acts as a mediator of many common allergic responses. It's also a defender against parasitic infections. It's the most commonly found in the body, and it's honestly the most commonly given in the field. It's transported across the placenta. It's effective against bacteria, viruses, and other toxins. The IgM, so this is the largest of the Igs, and it's the first antibody produced during the primary response to an antigen, and this is expressed by those competent B cells. So the aging system, for the older adult, their immune system, their response goes down. They have a decreased immune function, it's less efficient. So because of that, they have increased infections, especially secondary infections from other primary sources. They have an increased production of autoantibodies, so this increases the risk of autoimmune disorders. They are at increased risk for producing malignant cells, and when we couple that with the fact that they can't destroy malignant cells as quickly as a younger person, it increases the risk for cancer, and also they're less likely to do well with cancer. They also have a decline in T cell production and function, and there is a decreased neutrophil production, which results in decreased immune capacity. Protein in elderly is also often deficient, and that impacts cellular immunity. So there's a lot going on with the older adult that makes them more likely to get sick. Immune cell disorders or immune disorders, primary immune dysfunction, B cell deficiencies. So one classification of these immune dysfunction involve the B cells. B cells are involved in producing that humoral immune response, which is the antibody response. An antibody or immunoglobulin is produced in response to a foreign substance known as an antigen. So B cell deficiencies involve a lack of differentiation of B cell precursors into mature B cells, or a lack of differentiation of B cells into plasma cells. So examples of these B cell deficiencies are XLA, common variable immune deficiency, selective immunoglobulin A, immunoglobulin G subclass deficiency. So primary immune dysfunction, the T cell deficiencies. So T lymphocytes include subtypes, the CD4 helper and the CD8 cytotoxic T cells. And we'll talk more about those CD4 helper cells when we talk about HIV and AIDS. But anyway, they're responsible for the cell-mediated immune response that protects against fungal, protozoan, viral, and intracellular bacterial infections. They're also responsible for controlling malignant cell proliferation and coordination of the immune response. T cell deficiencies lead to infections and other problems that are more severe than B cell deficiencies. An example of a T cell deficiency is DeGeorge's syndrome. There's also chronic mucocutaneous candidiasis and hyper-IgM syndrome. So we have a couple B cell and T cell deficiencies that are combined. So there's severe combined immune deficiency known as SCID. It's potentially fatal and it's a primary immunodeficiency. This involves a combined absence of T lymphocyte and B lymphocyte function, and there's at least 13 different genetic defects that can cause SCID. And then there's also Wiskett-Aldrich syndrome, and this results from combined B and T cell defects. So characteristics are recurrent infection, eczema, and thrombocytopenia. So bleeding is a pretty big problem with this disorder. This one, its inheritance is X-linked and it's recessive. So secondary immune dysfunction, so therapy-induced deficiencies. So these are caused from medications causing immunosuppression, radiation, surgery. So this is when we're kind of thinking about our steroids that lower function, our chemotherapy medications, our immunosuppressants. So immunosuppressant therapy, it's usually to treat autoimmune disorders or to prevent transplant, rejection. Chemo can lead to leukopenia, so a decrease in white blood cells, which also decreases cell-mediated and humoral responses, because when we decrease our white blood cells, we're also decreasing our lymphocytes. Radiation can destroy those types of cells. Also surgical removal of like lymph nodes, thymus, spleen, they can suppress the immune system as well. So medical management for this, it's primarily preventative. So it's trying to prevent the patient from getting more sick, so to say. So it's good hand washing, avoiding contact with people who have obvious infections, like a cough or cold, regular follow-up with providers. Any signs of infection, such as like fever, chills, cough, they must go to the doctor. Any signs of a urinary tract infection, anything like that, they need to report it immediately. The goal of managing this type of immune deficiency is to protect the patient from the infection. So nurses need to monitor any signs of infection like fever, chills, cloudy, foul-smelling urine. And that's about as much in depth we're going to go with this. Immune disorder. So an excessive immune response. So we already spoke about autoimmunity last week. So I'm not going to really go much into the autoimmune. I'm going to go into the hypersensitivity reactions. So a hypersensitivity reaction, that's when the immune response is overreactive to a foreign antigen. An antigen is a foreign protein that stimulates an immune response in a susceptible individual. Hypersensitivity reactions can be damaging to the body, they can cause discomfort, and they can be fatal. Fatal is usually that anaphylaxis. There's several different categories of hypersensitivity reactions, and they're divided into 5 types. The types are based on the specific mechanisms and mediators that are involved in the process, the source of the antigen, and the length of time that it takes for the reaction to occur. And we're going to talk about them in the next few slides. So hypersensitivity reaction type 1. So this is rapid or immediate. So it's a rapid or immediate allergic reaction. There can be local or an atopic reaction or a systemic reaction. The most common is that allergic rhinitis or hay fever, or a local reaction, so like those local hives. So the most severe is going to be your anaphylaxis, which is that systemic response. So for pathophysiology, the primary mediator of type 1 hypersensitivity reactions is that immunoglobulin E, so that IgE. The first time a patient's exposed to an allergen, IgE is produced. The IgE antibodies attach to mast cells, and then the next time the patient's exposed to that specific allergen, it binds to the IgE antibodies that are attached to the mast cells. This causes those mast cells to degranulate, releasing histamine and other chemicals such as leukotrienes, prostaglandins, and they cause smooth muscle contraction, vasodilation, increased vascular permeability, bronchoconstriction, and edema. So this results in those symptoms associated with the allergy. Clinically, so that allergic rhinitis is going to have that nasal discharge, sneezing, pruritus in the upper airways. The patient could complain of a headache or sinus pressure. They may have itchy, watery eyes. Diagnostics, so we're going to run a white blood cell count with differential, right? This test is going to reveal an increase in those eosinophils. If you remember, I said eosinophils can, or they are released when there's an allergic response. So this, again, indicates that allergy. Eosinophils are the key inflammatory cells seen in allergic rhinitis, and they increase, and the symptom severity increases. That normal count is 1 to 2%, and someone with severe seasonal allergic rhinitis might have an eosinophil count as high as 12%. Skin testing is performed to determine the specific allergen. Various allergens are introduced via scratch test to determine which one is causing that positive reaction. That's when you see like that, like when patients have like those like lines on their back and they put a different allergen in like each little box. So the result of this is to determine the cause, and like a localized reaction would occur. They call it a wheel, and that's a positive result. It's usually within 15 to 20 minutes. So treatment, usually it's glucocorticoids or antihistamines, and these, if the patient's on these already, if they're going to have testing, they need to discontinue them 5 days prior. They also may discontinue NSAIDs prior. The forearm or the back are the ones that are often used for these testing. So treatment. Obviously avoid the cause. If you know you're allergic to something, avoid it. If a reaction does occur but it's mild, maybe removing the offending agent will be the only necessary thing. But if the symptoms persist, we might need antihistamines and decongestants. Decongestants are used to decrease the edema and lower the secretions. Diphenhydramine or your Benadryl, that is that antihistamine that decreases edema and constriction of smooth muscle in respiratory tract and blood vessels. Steroids might be used. This decreases that inflammatory response and decreases mast cell degradation. Beta agonist bronchodilators, so like your inhalers may be used if like there's respiratory distress going on, because that will help relax that respiratory muscle, the smooth muscle. Teaching. So educate your patient regarding potential causes in the environment, ways to avoid exposure to the allergen. Minimize any potential allergen exposure so that we can prevent any future reaction. Educate that patient regarding the signs and symptoms of the initial reaction. Rash and itching. The patient should know the possible signs and symptoms of a reaction to be able to react in a timely manner and prevent a more serious reaction. So anaphylaxis. So this is a systemic response to that allergic, like that type 1 hypersensitivity. So systemic response. So now the patient, they're short of breath, they have wheezes, they have crackles, skin reaction, nausea, vomiting, diarrhea, anxiety, a flush of heat, angioedema, bronchospasms, hoarseness, stridor. This is a systemic response, and it's an immediate response to the allergen. Patient's going to immediately complain of shortness of breath or feel like they feel tightening in their throat. You might see a rash on their skin. They usually feel anxiety, because think about if you're not breathing well, you're going to have anxiety. Angioedema, that's the swelling that's below the surface of the skin, and it's often around the mouth and eyes. So in an extreme anaphylactic reaction, there's a severe and rapid onset of symptoms. That's bronchospasm with extreme dyspnea and shortness of breath, as well as wheezing. These patients might have hoarseness and stridor. They're going to have a high-pitched crowing sound, which that indicates their airways are narrowing because it's constricting, right? Severe untreated reactions result in anaphylactic shock, which makes them hypotensive tachycardia, and that's because of vasodilation. So these patients, we need to immediately assess their airway. That's priority with an anaphylaxis patient, their airway. Put them in high Fowler's position. Treat them. Remember, this is an emergency, so if the causative agent can be removed right then and there, remove it. Yeah, we might do antihistamines, decongestant steroids, those bronchodilators, but this patient's probably going to need oxygen and epinephrine. We could do IV steroids. We could do topical steroids. They could even need up to cardiopulmonary resuscitation. I mean, you can die from this. It's severe, it's deadly. So elevate that head of the bed for these patients, assess their airway, and administer whatever meds that the doctor is ordering. Now for patient education. So we need to educate the patient on use of an EpiPen. The EpiPen, it injects a small amount or a small dose of epinephrine when the patient's exposed to an allergen, especially when they're at risk. So advise patient to obtain a medic alert bracelet or like a pendant, because this can kind of let healthcare professionals know if a patient comes in and we, John Doe, we know nothing about him, and we see that bracelet and then we find out they were at like a peanut factory, like, okay, there's our answer. And then for these patients with the EpiPen, we need to make sure that they are always carrying it, but also that it's not expired, because some patients are like, yeah, my EpiPen, I have my EpiPen, but their EpiPen actually expired like 5 years ago. And if the patient does use their EpiPen, they need to go to the ER for emergency care. It's not, oh, I did my EpiPen, I'm fine. Like, they need follow-up care because that reaction can come back. So the hypersensitivity reaction type 2. So there's two very common times that this reaction occurs. So one is the Rh factor sensitization, and this is the maternal fetal. So it's when fetal cells get into maternal blood, or fetal blood gets into the maternal blood, and there's a reaction because the Rh factor does not align. So mom ends up having a reaction. It can be deadly. But then there's also the blood transfusion reaction. So this is something that we see more often, especially for med-surg. So if you're giving blood and your patient starts having signs of a reaction, like they are short of breath, they have a fever, they're all of a sudden complaining of back pain, they are itching, they have a rash, any signs of like a hypersensitivity where you're thinking, oh, they're having a reaction to this blood, you need to immediately, and I mean immediately, stop the transfusion. Press off at the pump, unhook the blood from your patient, and then we're going to obtain new tubing, get normal saline, and infuse the patient. Then you need to call your doctor or call a rapid response, depending on what level your patient is. Obviously, if you go in the room and your patient's, full on like respiratory distress, you need to call a rapid response. But initially, stop the transfusion, obtain new tubing, and get some normal saline infusing in that patient, and then call your doctor. So hypersensitivity reaction type 3. So these are immune complex mediated reactions that occur when there's a formation of that antigen-antibody complexes. So it's kind of similar to type 1, and there's two different categories of this type 3. It could be local or immune. So local is that Arthus reaction, and that's localized vasculitis due to a deposit of immune complexes in a dermal vessel. This is after an intradermal or subcutaneous injection, so commonly vaccinations. So usually it's within like 4 to 10 hours, a red raised lesion appears at the site of the injection, and then like an ulcer will form in the center. And that's just due to the in situ formation of antigen and antibody complexes. Then we have systemic, which is going to be our SLE, so that lupus, RA, rheumatoid arthritis, and serum sickness. So serum sickness, that's an immune response reaction to certain types of medications, commonly penicillin, other antibiotics, or injection proteins, specifically antiserum. Antiserum is usually given after a snake bite, so that's that anti-venom, so to say. So serum sickness, it occurs, the body mistakenly identifies a protein from antiserum or a medication as harmful, and it activates an immune response to fight it off. So this results in a collection of immune complexes in small vessels of the skin, joints, kidneys. The depositive complexes activate the complement system, and then it increases vascular permeability. Phagocytic cells are recruited to the area, and then it actually causes a lot of edema and tissue damage. So this usually develops 7 to 10 days after the initial exposure, but sometimes can take as long as 3 weeks. So if the patient's exposed to the substance for a second time, this tends to develop faster within 1 to 4 days. And a very small amount can actually cause a very intense immune response. Serum sickness is less common because vaccines are made with human proteins rather than animal-based, and we don't really give the antiserum that often. So clinical manifestations, we're thinking fever, arthralgia, swollen lymph nodes, malaise, maybe arthritis or polyarthritis, which is arthritis in multiple joints, nephritis, so that's inflammation in that kidney, urticaria, which is hives, patchy or generalized rash. There could be extensive edema involving the face, which is that angioedema, or it could be in the neck and joints. And symptoms usually last only a few days, and the damage is usually temporary. But prolonged exposure can actually, it can lead to irreversible damage. In extreme cases, that serum sickness can be fatal. So medical management. So remove the offending agent. That's obviously the first line of treatment. And then we need to treat the systemic immune complex reaction. So we can do NSAIDs for joint pain, antihistamines for pruritus, so that itching. For severe reactions, again, we're going to go with that epinephrine, systemic corticosteroids. And that's about it for this one. Type 4 hypersensitivity. So this is a delayed type hypersensitivity, and examples are the poison ivy, the Mantoux test for tuberculosis, and latex. So some patients can experience a mixed type 1 and type 4 reaction. A latex allergy can be an immediate type 1 hypersensitivity or a type 4. It's more commonly a type 4. So patho, the type 4 cell-mediated and delayed type hypersensitivity is also known as a cell-mediated immune memory response or antibody independent. This reaction is different from the previous reactions in that it's mediated by cells rather than antibodies. This type of hypersensitivity reaction is delayed and is regulated by T lymphocytes that are damaging to cells or cytotoxic. The reaction usually occurs 24 hours to 72 hours after the exposure. So sensitized T lymphocytes are the cells that attack the antigens, and they release cytokines and they mediate the reaction. The macrophages and enzymes relieve the macrophages that are responsible for most of the tissue destruction. So in a delayed hypersensitivity reaction, it takes that longer time to occur. Clinical manifestations of the local reaction type are a positive TB test, which would be like that wheal or flare reaction. And this type is like that raised area containing edematous fluid surrounded by red flare. The clinical manifestations of that latex allergy can range from contact dermatitis, rhinitis, conjunctitis, pharyngeal edema, to that severe reaction all the way up to anaphylactic shock. So treatment, it's based on prevention, so avoid the products, avoid latex. If the exposure does occur, antihistamines can help with the less severe. We could do skin creams like topical steroids. For a more severe reaction, or like that repeated exposure reaction, they might need to go to the hospital for that emergency treatment with the oxygen, epinephrine, IV corticosteroids, to reduce that inflammatory response. Moving along, so hypersensitivity reaction type 5. So this can be noted as a distinct subcategory, but it's sometimes included in type 2 hypersensitivity reactions. So it's an antibody-mediated cellular dysfunction that leads to a change in cell function, but it does not lead to cell death like in type 2. The reaction is called a stimulatory reaction, and there's an excessive stimulation of a normal cell surface receptor by an autoantibody. The stimulation results in the continuous turned-on state for a cell. An example of this is Graves' disease. So it's a form of hyperthyroidism. It's an autoantibody. It binds to the thyroid-stimulating hormone receptor sites on the thyroid gland, and then the action of binding results in continual stimulation of thyroid cells to produce thyroid hormone. Normal feedback system for this is no longer working to stop that overproduction of thyroid hormones, so then they become hyperthyroid. HIV, so the human immunodeficiency virus, HIV. So this is a virus that attacks the body's immune system, and if it's not treated, it will lead to AIDS, that acquired immunodeficiency syndrome. There is currently no effective cure, and once people have HIV, they have it for life. With proper medical care, HIV can be controlled, and people who get effective HIV treatment can live long, healthy lives and protect their partners. So transmission can be viral. It could be acute viral or seroconversion. So when a person's first infected with the HIV virus, it causes an inflammatory reaction, which brings white blood cells and macrophages to the site of inoculation with the virus. So the site of where the virus first starts inoculating. So virus particle attaches to a specific receptor on the CD4 cell, CD4 receptors and co-receptors, and they enter the cell. Once inside the cell, viral RNA is changed to viral DNA using the enzyme reverse transcriptase. The viral DNA is then integrated with CD4 lymphocyte cellular DNA in the nucleus of the lymphocyte. The HIV DNA is now in charge of cell reproduction and produces a new viral protein. Boston stop. Asymptomatic chronic infection. So the immune system begins to exert control, but is not able to eliminate viral replication. The CD4 count increases to near normal. The viral load drops to set a point level. The viral set point occurs when viral replication is still taking place, but the immune system is able to destroy the virus in equal amounts as it's being produced. So this is that asymptomatic chronic infection. So we'll actually have patients that they get the lab testing, and even though they've had AIDS for HIV for years, it's showing like they don't have it, even though they do. Systematic chronic infection. As HIV infected individuals' CD4 count continues to fall, control over viral replication is slowly lost. The immune system becomes less able to fight off infections, and individuals begin to develop nonspecific symptoms. And this could be like respiratory tract infections, skin problems, enlarged lymph nodes, weight loss. So HIV is commonly a sexually transmitted disease, and although a significant number of individuals contract the disease from IV drug use, blood containing the HIV and virus is injected into the bloodstream of an uninfected individual from an infected individual, and that's when needles are shared. A very small number of individuals are still infected from blood transfusions. If someone's pregnant or breastfeeding, they can actually transmit the HIV to their child. So signs and symptoms. There's fever, cough, weakness, nausea, vomiting, diarrhea, dysphagia, difficulty swallowing, forgetfulness, skin lesions, shortness of breath, dyspnea, on exertion. I don't know why I have a comma there. Headache, vision changes, pain, night sweats, that swollen lymph nodes. So what is AIDS? So it's the most advanced stage of that HIV infection, and it's defined by the occurrence of any of the more than 20 life-threatening cancers or opportunistic infections that happen when someone has HIV. So with that, so when someone has AIDS, the CD4 count continues to fall, and the immune system is less and less able to fight off infections. So infections can use the, in quote, opportunity of non-functioning immune system to infect the body, or the immune system loses the ability to control infections that are in a dormant phase, and this allows the infection to become reactivated. So an HIV-infected individual has AIDS when the CD4 count is less than 200 cells, or when they're diagnosed with one or more of those AIDS-defining illnesses. And the symptoms, again, it's of the opportunistic infection, so it's going to relate to that specific infection that they have. There could be rapid weight loss, there could be fever, unexplained tiredness, sores. But again, we're going to need to look at the opportunistic infection that's happening to know specific. So HIV classifications. So there is stage 1, and that is when the CD4 count is at least 500. Stage 2 is when it's 200 to 400, and then that HIV infection that has become AIDS is when they fall less than 200. All right, so the labs. So those CD4 cells, those are also known as the helper T cells or just the T cells, and it's an important part of your immune system. So the CD4 cells, they fight off infections and they help keep you from getting sick. So the more CD4 cells you have in your body, the healthier you'll be. HIV attacks and destroys those CD4 cells, so obviously it's going to make a patient more likely to be infected. So your normal CD4 count is going to be that 500 to 1500. Patients might show those infections and have AIDS when they get to less than 200. And again, yeah, less than 200 is AIDS. So there is an ELISA test, and that's used to detect HIV infection. And when that's positive, we end up using the Western blot as well, just to confirm that diagnosis. For the Western blot, a small sample of blood's taken, and then they look at it under a microscope, and it's used to detect HIV antibodies, not the actual virus itself. All right, so our HIV/AIDS treatment and education. So as I kind of said, there is no cure. We really want to focus on prevention of those opportunistic infections and the HIV itself getting worse. So antiretroviral, that's the current recommendation for all patients that have HIV. And this medication, so it works to interfere with the ability of HIV to reproduce itself. These meds need to be prescribed and given on time. We need to maintain this medication level, and that's actually critical to prevent any medication resistance. So with that, we'll treat symptoms, any symptoms the patient's having. So obviously if they're nauseous, we'll give them Zofran. Like we'll treat any symptoms that they're having. Prevent and treat those opportunistic infections. So common infections, there is a lot of common ones, but toxoplasmosis is one and Kaposi sarcoma is another. These patients need immunizations to help prevent, like pneumonia and stuff like that. But we never want to give them a live vaccine. And a live vaccine, so an example of it is varicella. If their CD4 is decreasing and they're getting, AIDS level and whatnot, we need to put them in protective isolation. They need to avoid crowds and be in that protective, like almost like that neutropenic precaution type situation. So patient teaching. So there is screening. So right now it's recommended that all providers do offer screening to patients for HIV. Yearly testing is recommended for those that are at high risk. Then there's that PrEP Truvada. I'm sure you've all seen commercials for it. So that's a combination of medications. It's tenofovir and emtricitabine. I'm not going to test you on that. So it's pre-exposure prophylaxis. That's what PrEP stands for, pre-exposure prophylaxis. So that is how you prevent from getting AIDS. And this is approved for daily use to reduce that risk of acquiring the HIV. So teaching. Avoid high-risk behaviors. So, teaching patients about safe sex, avoiding street drugs, situations that might impair judgment that could, increase the risk of getting HIV, or if you have HIV, reduce the risk of transmitting it. Adherence to treatment regimen, so they, need to make sure that they're taking their med as ordered at the same time every single day. They need to plan their administration around any activities of daily living because they must maintain that therapeutic level. They need to understand the name, the purpose, the dosage of the medications, how to take it, any side effects, how to manage them to contribute to maintaining that 95% adherence. They need to know how to implement infection control precautions at home. They need to, understand the fear of transmission to other household members. Like, using the same fork's not going to give HIV. But they also need to know specific methods of infection control, such as protecting others from blood spills. They need to be cleaned with bleach. They need to avoid raw or undercooked eggs, meat, poultry, fish, and that's just to, reduce the risk of like diarrheal illnesses. So if like animal excretion, like they have a cat, toxoplasmosis is very common with that. So if they have a cat, they shouldn't be changing the litter box. Someone else needs to do it. Signs and symptoms that they need to report to the healthcare provider. So they need to be evaluated immediately, especially if they have like a fever, sudden onset of acute infusion. We need to explain how to utilize like a self-care symptom management manual for them. And then a lot of therapeutic communication with these patients. Nursing safety with the HIV/AIDS patient. We need to utilize universal precautions consistently. Universal precautions are designed to prevent the spread of infections between individuals. So we need to do hand washing for a minimum of 15 to 30 seconds, and that's the most important precaution. We need to consider personal protective equipment, and that's like your gloves, goggles, gowns, and this is when you're at risk for exposure. This is a review, so the routes of transmission. So there's vector-borne transmission, and that's an indirect mode of transmission. And it occurs when a vector, such as like a tick, a bite, some kind of organism transmits a pathogen into a person. We have contact. So this is the most common mode of transmission. And this mode, pathogens are transmitted directly from person to person or whatever to the person. Okay, and then we have our airborne. So that's obviously, it's traveling through the air. Vehicle, and that's food to mouth, like so ingestion. And we have droplet, which is your coughing, sneezing, and saliva. Now you need to be familiar with your different precautions for each, okay? So influenza, I'm just going to quickly go over this. So your risk factor or pathophysiology is being exposed to the influenza virus. It does require droplet precautions, and there is an immunization to help prevent it. An egg allergy is a contraindication to that immunization. Manifestation, so this is going to be your cold symptoms, fever, fatigue, body aches, and someone is infectious for 7 to 10 days. So we need to give our patient education on that flu shot, and we need to make sure that they understand that the flu shot does not give the patient the flu. So our multi-drug resistant organisms, or MDROs, we have our MRSA, VRE, C. diff, Acetobacter baumannii, and then CRE. So this is a result of decades of unnecessary antibiotic use, and it's currently resistant to all beta-lactam antibiotics, which include penicillins, cephalosporins, carbapenems, and the pathophysiology is direct contact with the pathogen. Risk factors for this include hospitalization, especially in the past 12 months, a soft tissue infection on that hospital admission, intensive care unit, residing in a long-term care facility, invasive procedures, medical devices like a urinary catheter or an IV line, hemodialysis, long-term or recent broad-spectrum antibiotic therapy allowing bacteria to become resistant to that specific antibiotic. And then other risk factors are people with immune systems that are weak or immature. So young children less than 2 years of age, our elderly, people with HIV or AIDS, as well as other comorbid conditions like your diabetes, cancer, COPD, immunosuppression, autoimmune disorders, congestive heart failure. Clinical manifestations, so it really depends on what they have. So there can be minor skin infections, like a pimple, an abscess, a stye. And then there could also be more serious, like a pneumonia or a skin and soft tissue infection, a surgical site infection, or a bloodstream infection. Infections with MRSA are associated with increased morbidity and mortality. The overall rate is 20 to 50%. So this can also lead to osteomyelitis and toxic shock syndrome. If it's untreated, it can ultimately lead to more multi-system organ failure and death. VRE, this one, so our risk factors are pretty much the same as the MRSA ones, and patho is very similar as well, so that direct contact from skin or patient equipment. Manifestation, so the symptoms are going to depend on where the actual VRE is located. I have always seen it in the urinary tract, so VRE urinary tract infections, but it can also be in the belly, that peritonitis, or bacteremia, or a wound infection. Complications, so this can lead to a prolonged hospital stay, prolonged antibiotic therapy, again, higher mortality, and endocarditis. So a fan favorite. So this is the most common antibiotic-associated diarrhea in the United States, and it's actually responsible for 12% of all hospital-acquired infections. So risk factors, that's that use of antimicrobials, because when we use antibiotics, we wipe out the good bacteria, so then the body has a chance to grow the bad bacteria. And these antimicrobials are like particularly clindamycin, cephalosporins, and fluoroquinolones. And then other risk factors are an age greater than 64, a long hospitalization, immunosuppression, chemotherapy, different NG tubes and like oral feeding tubes, underlying illnesses. So the greater number of antimicrobials and the greater number of doses and the greater duration of administration increase the risk. So the more use of antimicrobials, the higher the risk. So it's a spore-forming gram-positive anaerobic bacillus. And these spores are resistant to many types of disinfectants, heat, and dryness. And they can live on surfaces for months. They can live on skin folds and hands of healthcare workers, and they're transmitted the oral fecal route. This occurs when a pathogen from species is introduced into the oral cavity of a host. It is almost exclusively found in healthcare settings. The hands of healthcare workers are the primary source for the C. diff spread. Environmental contamination is also a means by which the organism is spread, and that's secondary to its ability to survive on the environment for long periods of time. It can also be spread from person-to-person contact. Thus, a patient with C. diff must be put on contact isolation precautions. People who develop C. diff infections test positive for C. diff toxins in their stool, and although they might be asymptomatic, the most common clinical manifestation is that mild to moderate diarrhea. The treatment for C. diff is your oral Vanco, and the complications, and there's many, but so volume depletion, renal insufficiency, electrolyte imbalance. Just think about someone having a ton of diarrhea. The low albumin, peritonitis, paralytic ileus, toxic megacolon, fulfillment, pseudomembrane colitis, sepsis, and death. Abomani, so risk factors, that's going to be our recent surgery, our central venous catheters, trachs, mechanical ventilation, enteral feedings, exposure to antimicrobials, vascular catheters, and then also the respiratory tract. So your vascular catheters and your respiratory tract are the most common places where this infection is found. So pathophysiology. So this is a non-fermentive aerobic gram-negative coccobacillus, and it's naturally in the water, soil, animal, and humans. This can grow at various temperatures and various pHs. This organism can survive for weeks to months on both dry and moist surfaces, and it promotes transmission via contamination in hospital settings. So this can infect or colonize the body at many sites. So typically it colonizes in that respiratory tract or blood, but also pleural fluid, the peritoneum, urinary tract, surgical wounds, and the central nervous system, skin, and eyes. Ventilator-associated pneumonia and or bloodstream infections are the most common types of this abomani. So complications, so this increases mortality, the length of the hospital stay, the length of ventilator days. They have a 5-day excess length of ventilation compared to patients without this infection. They could prolong the ICU stay for 6 days. And it's difficult to prove secondary to the patient's severe underlying illnesses, the associated crude mortality rates. PRE, the risk factors are pretty much the same as the other ones, okay? So it's any disorder or treatment that disturbs the body's natural flora. So there's an increase in individuals that are older, long-term hospital stays, ICU, and so on. So for this one, this could be Klebsiella or E. coli, and these organisms are normally found in the intestines, where they are typically harmless if contained. But if they spread outside the intestine, they cause serious infections. They can cause UTIs, bloodstream infections, wound infections, and pneumonia. So infections with CRE are usually spread through direct contact with infected or colonized people. particularly contact with wounds or stool. The resistance of CRE to the carbapenems is caused by two main mechanisms. One, the activity of B-lactamase enzymes that result in resistance to the B-lactam antibiotics. Two, the production of carbapenemases, enzymes that hydrolyze or break down the compounds of the antibiotics. Manifestations, so these vary depending on the location of the infection. So bloodstream, pneumonia, wound infections, UTIs. Common symptoms are fevers, chills, and signs of sepsis if the infection has not been successfully controlled. So the CRE, the strains of bacteria are resistant to that carbapenem, and this antibiotic is usually a last resort to treat a severe infection when other antibiotics have failed. So we're already using a last resort to treat this patient, and then we find out this patient is got a CRE resistant, or a carbapenem resistant organism. So they're very dangerous, and they're difficult because they become resistant to pretty much all available antibiotics. So because of this, mortality is extremely, extremely high. Precautions. So this is kind of a review from semester 5. Feel free to pause this slide and kind of read through them. I'm not going to read through them, but if you want to pause and look at it, you absolutely can. You do need to know these. MRDO management. So diagnosis, you need a culture and sensitivity. So your culture is going to figure out what type of organism, and your sensitivity is going to figure out what type of antibiotic will actually treat the organism. Clinically, again, it's going to depend on which organism and where it's infecting, but fever, tachycardia, tachypnea, hypovolemia, and diarrhea are all common. You want to assess these patients. You want to look at their vital signs. How's their pain? How's their skin turgor? Are they dehydrated? What's their urine output? If it's less than 30 mLs per hour, we have a problem. We want to check their skin, look at for any wounds. What's their WBC count? Think back to your leukocytes and your lymphocytes. How's their creatinine? How's their BUN? What's their kidney function? Electrolytes? What are their bowel movements looking like? Treatment prevention. So again, your hand hygiene, your isolation, your medications. We want to prevent the spread. We want to prevent it from getting worse. And then I have a list, and I do want you to familiarize yourself a little bit with the list of medications for each one. We'll go over more specifically in class, okay? Sepsis, SIRS, and MODS. So this is just going to be a quick overview. So sepsis is a life-threatening organ dysfunction, and it's caused by a deregulation host response to infection. So for sepsis, we need lab stat. We have to do a serum lactate right away, and we need 2 sets of blood cultures. These blood cultures must be prior to the antibiotic administration. And that's because if you give antibiotics and then obtain blood cultures, you're already fighting the bacteria, and you're administering these antibiotics into the bloodstream. So we might get a false read that there's nothing there when there really is something there. Additionally, we need to draw CBC. We need differentials. We need to look at those white blood cell counts, look at those neutrophils, see what's going on. Coagulants, we need to see how's the blood coagulating. A CMP, electrolytes, LFTs, ABG, maybe this patient's, going downhill. Are they compensating? We'll talk more about that when we talk about ABGs. If there's a wound, we need to culture it. What bacteria is inside that wound? We need to administer broad spectrum antibiotics. Until we know that sensitivity part, we need to just do a broad spectrum, so we try to, kind of cover everything. And then if the patient's hypotensive, we're going to do 30 mLs per kilogram of crystalloids of an IV infusion. Monitor those vital signs closely. We need to assess all of them: blood pressure, your temperature, your oxygen, all the different vital signs. So our temperature in sepsis increases, our heart rate increases, our respiratory rate's going to increase. Our blood pressure might drop if they're compensating, and our SpO2 could drop if they're compensating. So monitor that urine output. Again, it needs to be greater than 30 mLs per hour. If it's less, they're having signs of organ dysfunction. we need to call the doctor. This is a problem. SIRS is a systemic inflammatory response syndrome, and that's an exaggerating defense response of the body to a noxious stressor. And then we have complication of sepsis of multiple organ dysfunction syndrome, and this is when all the organs start failing, and this is a result of excessive inflammation. This is not good. Lastly, please review the precautions. Know your precautions for your HIV and AIDS, your C. diff, your MRSA, your VRE, influenza. You really need to know those as well. And again, we'll get a little bit more specific in class. Thank you, and I hope you guys enjoy the presentation.